Hi again, everybody. So this will be a talk on microcytic anemia. And microcytic anemia is anemia, so anemic symptoms, fatigue, weakness, malaise, pallor, in conjunction with a low MCV. MCV is mean corpuscular volume. It's the average size of the red blood cells in the circulation. So it's normally 80 to 100 femtoliters. With a low MCV, it will be below 80. So overwhelmingly, the number one cause of microcytic anemia is iron-deficiency anemia. Iron is needed to make hemoglobin. If you don't have iron, you don't have hemoglobin. You can't fill up your red blood cells. And so this can be due to a deficiency of iron intake. It can be due to chronic blood loss. Where do you have chronic blood loss? Slow GI bleed, like a bleeding ulcer. Menorrhagia or mild hematuria. So number one cause, iron deficiency anemia. How about patients who have lifelong microcytic anemia? It's congenital. That's a thalassemia. Thalassemias are congenital conditions and they manifest as well as microcytic anemias. Now, one of the ways you're going to tell this apart from the peripheral blood smear, a way you can tell this apart from iron deficiency is that you're going to, in thalassemia, you're going to have a really low MCV, disproportionate to your degree of anemia. So, for instance, and these aren't necessarily scientific numbers, but let's say in iron deficiency anemia, you could have a hemoglobin of 9, so you're anemic, with an MCV of 75. So it's slightly below the cutoff of 80. With thalassemia, you could have a hemoglobin of 9 and an MCV of 60. So it's much lower MCV in thalassemias. So think of the thalassemias when you have a patient that has had a congenital blood condition their whole life, there's a family history, and they have a really low MCV that's disproportionate to the degree of anemia. Sideroblastic anemia is another congenital condition. However, it can also be linked to cancer and various toxins. Sideroblastic anemia is a defect in the production of heme. So while thalassemias are a deficiency in the production of globins, sideroblastic anemia is a deficiency in the production of heme. So various toxins can include alcohol, isoniazid, lead, chloramphenicol, other heavy metals. You should think of sideroblastic anemia when you hear the term basophilic stippling, and I'll show you a picture of what that looks like. And then sometimes anemia of chronic disease can be microcytic, and of course you should think of anemia of chronic disease when you have an anemic patient who also has a chronic disease. Okay, so microcytic anemia. Whenever you have a patient with a low hemoglobin and a low MCV, because the number one cause is iron deficiency anemia, to confirm that iron deficiency anemia, you should always first get a serum ferritin, a serum iron level, and a TIBC, which is total iron binding capacity. And a total iron binding capacity, TIBC, is an indirect way we can measure transferrin, which is a protein that carries iron in the serum. So these labs altogether are known as iron studies. So when you hear me say get iron studies, I'm saying you're going to get these 3 labs at least. So iron is carried intracellularly in the blood, and it's also carried in the serum. So the intracellular iron, that says serum ferritin because you're getting it out of the serum, but I suppose this would be just ferritin. Cross out serum there. So intracellular iron, this is iron that is in the blood, but it's not attached to hemoglobin. So ferritin levels, of course, measure the amount of ferritin in the blood. Ferritin is a protein that's created to store iron in cells because iron is toxic to cells. So ferritin is also an acute phase reactant. So you may have high ferritin, but that doesn't necessarily mean that you have a high hemoglobin because hemoglobin needs iron attached to it. Ferritin holds iron. So ferritin can hog iron from hemoglobin. We see a condition where that actually does happen. So ferritin is an acute phase reactant, so it's going to be elevated in any patient that's got any kind of inflammation. So keep that in mind. Okay, now iron is also in the serum. It's extracellular as well. And so you can have serum iron, and that just measures the amount of free iron in the serum, but the majority of iron that's in the serum is attached to transferrin. So to measure transferrin, we measure the TIBC. That's just a laboratory measurement, and that's an indirect measure of transferrin. So if your TIBC is high, your transferrin is high. If your TIBC is low, your transferrin is low. Generally, with iron deficiency anemia, our transferrin goes up. Why does it go up? Because transferrin is going to be made to look for all the possible iron it can find to bring it in to the red blood cells. Okay, so how do we work with these labs? So whenever you have a patient with low hemoglobin, as I mentioned, you should get your iron studies. Ferritin is a protein created to store iron in the cells, as I mentioned, and it elevates to sequester iron from bacteria that can thrive off of it as an acute phase reactant. So this is going to be important when we talk about anemia of chronic disease. So in anemia of chronic disease, what we have is chronic inflammation. Chronic inflammation can be due to bacteria. Not always. It could be due to an autoimmune disorder, but a lot of times it's due to a bacteria. There are a lot of bacteria, E. coli, Klebsiella, that love to eat iron. They thrive off iron. So a great response for your body would be to make a protein that holds on to that iron so the bacteria can't eat it. And indeed, what happens in anemia of chronic disease is that your ferritin elevates and it sequesters iron from the bacteria. And in the case of iron deficiency, ferritin is going to drop so it can free up iron to become heme. Now, ferritin is not transferrin. Those are different. Ferritin is intracellular. Transferrin is extracellular. So ferritin drops when you have an iron deficiency because ferritin can hog iron from the hemoglobin, from heme. So if you have less ferritin, then you've got more iron that can go and become hemoglobin. So it drops in the presence of iron deficiency. Elevates in inflammation, drops with iron deficiency. And remember, it's an acute phase reactant, and that makes sense because it elevates due to inflammation. Serum iron, we mentioned, measures the amount of free iron in the serum, and then we talked about TIBC is a measure of transferrin. Transferrin elevates in the presence of iron deficiency, and that's just a futile attempt to gather more iron. It's also going to decrease in the presence of anemia of chronic disease because we want less iron around in the serum when we have inflammation. We'll talk about that more in depth in a bit. Okay, so here are the iron studies in microcytic anemia. With serum ferritin, serum iron, and TIBC, this will help you figure out what your disease is. So we talked about iron deficiency anemia, thalassemia, anemia of chronic disease, and sideroblastic anemia. So iron deficiency anemia, you've got a low ferritin. Why do you have a low ferritin? Because you don't have any iron to bind to it. So your ferritin goes down, and that's going to allow any remaining iron in the cell to become hemoglobin. You have a low serum iron, well, it's iron deficiency anemia, so that makes perfect sense. And you have a high TIBC. Why do you have a high TIBC? Because transferrin looks for iron. With thalassemia, it's all going to be normal. This is just a congenital disease. With anemia of chronic disease, you have a high serum ferritin. Why do you have a high serum ferritin? Because you want to pull in all the possible iron into the cells that you can. You want no iron in the serum. You could have a normal serum iron, but it will tend to be normal to low. And TIBC will be low because you don't want iron in the serum. Sideroblastic anemia, you're going to have, again here, a high serum ferritin. And with sideroblastic anemia, the iron can't incorporate in to become heme. And so you've got all this iron left over that can't go in to become hemoglobin. So you have a high serum ferritin, a high serum iron, and the TIBC is not effective. Okay, so maybe this will help you figure out what these 4 diseases are before we talk about them in detail. So what do we do when we make heme and globin? Well, let's talk about globin first. Globin is a protein, so we start off from DNA, transcribes it to RNA, translates it into a protein. So you've got alpha globin and a beta globin. With hemoglobin A, you have 2 alphas and 2 betas. They come together, and that's globin A. It will become hemoglobin A when it combines with heme. Now for heme synthesis, you've got glycine and succinyl-CoA converting to delta ALA. You don't need to know these steps. Ultimately, it forms protoporphyrin 9. What then happens is it gets associated with iron, and then that becomes heme. If it can't associate with iron, then you can't get heme production. And if there's any defect in heme synthesis, then you get a sideroblastic anemia. If there's a defect in globin synthesis, then you get one of the thalassemias. If there is a mutation in the DNA, and the mutation I'm talking about is particularly on the part that codes for the beta globin, you can get sickle cell disease, and so on and so forth. So you can see I've got all of these diseases marked on here. Okay, let's talk about them in detail though. Okay, iron deficiency anemia. So this is the most common form of anemia, and it's the most common form of anemia because it's due to blood loss, and you can have blood loss very easily. Women lose blood every month when they're menstruating, and you can lose blood if you have an ulcer, and so losing blood is common. Particularly, it's common when it's small blood losses at a time, and if you can't recompensate, you can get iron deficiency anemia. One of the unusual symptoms, in addition to the anemic symptoms, when you have iron deficiency anemia is a symptom flat out due to the lack of iron, and that is pica. So these people will chew on ice, they'll eat, some of them will even eat clay or dirt or whatever, so that's pica. So you should always think of iron deficiency anemia when you've got an anemia or low hemoglobin with a low MCV, and you've got low ferritin and low serum iron. Both of those show that you have low iron stores. Most cases of iron deficiency anemia are non-emergent, so primarily your job is going to be to investigate the cause, because with iron deficiency anemia, once we've diagnosed it, treating it is easy. We replace iron. But we want to know what the cause is, because sometimes iron deficiency anemia is a manifestation, a primary manifestation of colon cancer, where you're losing blood in small amounts out the rectum and the patient doesn't know it. So you have to consider iron deficiency anemia, yes, as something that needs to be treated, but as kind of a symptom of another disorder, possibly. So on iron studies, you're going to have a low ferritin, and the reason you have a low ferritin is because you have no need for it. You have low iron. And besides the fact, your body doesn't want to make ferritin because ferritin is going to hog iron away from becoming heme. You're going to have a low serum iron because you don't have it, and then you're going to have a high transferrin, high TIBC. That's going to be because it's trying to find as much iron as possible. And then an elevated red distribution width is common because you have you're going to have some very, very small red blood cells that don't have a lot of hemoglobin in it, and you may have some normal looking red blood cells. So tends to be with iron deficiency anemia that you have an elevated RDW. So the causes of iron deficiency anemia can be excess loss, increased requirements, or low absorption of iron. So excess loss would be things like menorrhagia, occult GI loss, which can be upper or lower, blood donation, and that would have to be some pretty fervent blood donation, occult hematuria, and so forth. Increased requirements can be in pregnancy and lactation, and low absorption would be in malabsorption, where you're not absorbing enough iron. So any patient with iron deficiency anemia, if they're over the age of 50, remember back to the GI lectures, you should consider getting a stool Guaiac test for GI bleed. Any patient 50 or older should be getting a colonoscopy every 10 years as part of routine surveillance. And if they've got a family history of colon cancer, perhaps even younger. But if you've got iron deficiency anemia in a patient over the age of 50, good idea to get a stool guaiac test to see if there's any kind of blood in the stool, because that could be a source. Remember what I said, iron deficiency anemia is something you need to treat, but it's also something that can point to something else. Most patients can get iron supplementation, and it's taken orally. Patients, however, with malabsorption can get parenteral iron supplementation. And you should check these patients again in 3 weeks. Their hemoglobin should improve. Okay, so what is globin? So globin is, hemoglobin, we've been talking about that. That's heme plus globin. So globin is the protein portion. Globin is a tetramer, so there's always 4 parts to globin. What 4 parts is the question. So the typical adult hemoglobin, which is hemoglobin A, is 2 alphas and 2 betas. So 2 alpha proteins and 2 beta proteins. There's also a different kind of adult hemoglobin, which is present in much smaller amounts, only about 1% normally, and that's hemoglobin A2. And that's 2 alpha parts and 2 delta parts. Now, fetuses make a special hemoglobin because of the different environment that they're in, and that's called fetal hemoglobin, or hemoglobin F, and that's made up of 2 alpha parts and 2 gamma parts. And they stop making those gamma parts and start making beta parts at around 6 months of age. So they should start making quote-unquote adult hemoglobin by the time they're 6 months to 1 year old. Now, alpha and the combination of beta and delta, beta to a much higher extent, they're made at a very tight ratio, 1:1. Why? Because for any of these, for hemoglobin A or for hemoglobin A2, you've always got 1 alpha per 1 beta, or 2 alphas for 2 betas, 2 alphas for 2 deltas. So you shouldn't be making significantly more alphas than you're making betas and deltas. So it should be at a tight 1:1 ratio. There should never be free alpha, beta, or delta around. There should never be, never in a normal person should there be any alpha 4 tetramers or beta 4 tetramers and so forth. So they're made at a controlled ratio. Okay, so what is thalassemia? So thalassemia, as mentioned, is a disorder in globin production. So microcytic anemia with normal iron studies. That's going to be the tip-off. However, it's very microcytic. Patients with thalassemia may have an anemia of 9.0 hemoglobin, but they've got an MCV of 60. Very, very, very low. What's going to point you, though, to thalassemia is that you've got normal or close to normal iron studies. In as much as the patient is anemic. So these patients are not iron deficient. So alpha thalassemia is a disorder of alpha production, and that makes sense. There are 4 genes that encode alpha production, so a person can miss 1, 2, 3, or even all 4 of their alpha genes. And the severity of their alpha thalassemia is going to be worse the more alpha genes they have missing. So most of us don't have any missing, but there are some people with 1 gene missing, some people with 2, some people with 3, and so forth. Beta thalassemia is a disorder of beta production, and there are only 2 genes to encode beta production. Now, a beta gene can be fully functional, and that's described as just beta. It can have low function, and that's described as beta plus, and non-functional, which is described as beta 0. If a patient has 1 normal gene, no matter what that second gene is, if a patient has at least 1 normal gene and 1 error gene, regardless of whether it's beta plus or beta 0, they're said to have beta thalassemia minor. And that's a less severe state, as mentioned when it says minor. So as long as they have 1 normal gene, they have nothing worse than beta thalassemia minor. Now, if the patient has 2 error genes, whether it's 2 beta positives, 2 beta zeros, or a beta positive and beta 0, Then they're said to have beta thalassemia major, also known as Cooley's anemia. And this is a more significant condition because they don't have any genes that encode a normal level of beta production. Okay, so let's go back to alpha thalassemia. What is it? Remember, disorder of alpha unit production. Alpha thalassemia tends to be more prominent among Asians and blacks, and the thought is because alpha thalassemia trait is protective against malaria, just like sickle cell disease. So Asians and blacks are more likely to have alpha thalassemia than other races. The symptoms are going to vary based on the severity, and again, this is based on the number of absent alpha genes. But it's going to include the usual weakness that we see in anemia, fatigue, malaise, and pallor. Splenomegaly can be seen. In addition, hyperbilirubinemia can be seen because of breakdown of any kind of abnormal cells. Bony abnormalities can be seen. Why bony abnormalities? Well, the jaw and the frontal bone in the head are possible sites of hematopoiesis. So if you don't have enough hemoglobin and you're anemic over a long period of time, your body is going to try to make more blood, and it's going to do that by trying to make it in unusual places, and those include the jaw and the frontal bone. So frontal bossing and jaw enlargement, not only are those signs of acromegaly, like we talked about in the endocrine chapter, but they can also be signs in anemic patients of very chronic anemia, like we see in alpha thalassemia. And then fractures can be complications as well, because what's in the middle of our long bones? Well, it's where we make our bone marrow, and it's where we make our blood. And if we're expanding the size of that bone marrow, we have to decrease the amount of bone. And so fractures can be complications of the thalassemias as well. So suspicion should be raised when you see a low MCV that's out of proportion to the anemia. You may even have a normal hemoglobin in the rare cases, but a very low MCV. Lab anomalies, again, are going to vary based on the severity. The best diagnostic test when you suspect alpha thalassemia, normal iron studies, low MCV, anemia, the best test for alpha thalassemia, or beta thalassemia for that matter, is a hemoglobin electrophoresis. Electrophoresis, remember, separates proteins, and that's going to help us determine how much alpha is there and how much beta is there. In an alpha thalassemia, because we have a disorder of alpha production, we don't have enough alpha production, we're going to have a very little amount of alpha and a normal amount of beta, and we will see that on the electrophoresis. The most accurate test, though, is not the electrophoresis, it's genetic testing, and that makes sense. Genetic testing is going to be more accurate because you're looking right at the genes rather than at the proteins. So this is normal, so you carry 2 alphas on one chromosome and 2 alphas on the other chromosome, one from mom, one from dad. So normal would be the 2 genes that code for alpha and the other 2 genes that code for alpha. A silent carrier would have 1 missing alpha, and they're called a silent carrier because they have no symptoms. Alpha thalassemia trait would be having 2 missing alpha genes. Now you could have that 1 missing alpha on one gene and 1 missing alpha on the other gene, or you could have 2 normal alphas on one gene and both missing alphas on the other gene. Either or, that's alpha thalassemia trait, and those patients will have minor clinical symptoms. Hemoglobin H disease is when you have 3 missing alpha genes, and that causes major clinical symptoms, major symptoms of thalassemia. These patients are going to be much more clinically sick. Now, we call it hemoglobin H disease because in these patients, in their blood, when we do the electrophoresis, we find beta-4 tetramers. Why would we have beta-4 tetramers? Because we have so little alpha production that actually beta globins can get together and form globins of 4 betas rather than 2 alphas and 2 betas that we would see in hemoglobin A. So 4 betas together is called hemoglobin H. And so that's why we call this hemoglobin H disease. And so we have abundant beta that doesn't have enough alpha to bind with. And then no alpha at all, that's hemoglobin Bart's, and that's generally, you don't survive that after birth. Usually they're stillbirth or they die shortly thereafter. And that's called hemoglobin BARTs because what you have in those patients are gamma tetramers. Because remember, what beta is in adults, gamma is in fetuses. So they have gamma 4 tetramers, and that's called hemoglobin BARTs. So this is just showing how the genes are passed on. So the treatment, whether or not you're going to treat or when you're going to treat, is going to be warranted based on the patient's symptoms and their overall state of health. So certainly if they're just a carrier or if they've only got 2 missing genes, you may not need to treat them. Iron supplementation is always contraindicated in patients with alpha thalassemia or beta thalassemia. Why? Because we have a problem with globin production. We don't have a problem with iron. And so iron supplementation is contraindicated. As a matter of fact, it's contraindicated because patients who have alpha thalassemia or beta thalassemia who are going to need treatment, the treatment is going to be transfusion. And when you give transfusion, you're giving normal hemoglobin. And what you're also giving in transfusion is iron. And so after you get transfusions over transfusions over transfusions, over time, you're going to collect excess iron. And so we don't want to be giving people extra iron when they're already predisposed to getting excess iron from their transfusions. When do we treat a patient with thalassemia? We treat them if they're highly symptomatic or if they have a hemoglobin of less than 7. Anytime you've got a hemoglobin of less than 7, it's transfusion time. And so most of the time, we're going to treat patients with hemoglobin H disease. However, minor alpha thalassemia, we can treat that too if they're highly symptomatic or if they have a hemoglobin of less than 7. Patients who have had repeated transfusions, as I mentioned, they are at risk for iron overload syndrome, another name for hemochromatosis, but this is not genetic hemocrosis, this is iatrogenic hemochromatosis because we're causing it from the repeated transfusions, and we can simply treat that with chelation therapy to take the iron off of their blood. And we can use deferoxamine or deferoxerox. If the patient goes on to develop hypersplenism, then a splenectomy is going to be indicated. And hypersplenism is very common in thalassemia. Long-term complication of alpha thalassemia is going to be symptoms that are, any kind of syndromes that are associated with increased hemolysis, so gallstones and hypersplenism are 2 of them. Infections and ulcers, thrombosis, and you can also get cardiac complications, restrictive cardiomyopathy from hemochromatosis. But we tend to prevent that by making sure that we monitor their serum iron levels. Okay, beta thalassemia. So beta thalassemia is just like alpha thalassemia, but it's a disorder of beta unit production, and the genetics are a little different. So it's more prominent among Mediterraneans, so Italians and Greeks. And there's another blood disease that's also common among Mediterraneans, and that's the G6PD deficiency. So beta thalassemia and G6PD deficiency are 2 diseases that we see more common in Mediterraneans. So beta thalassemia, the symptoms, again, are going to depend on whether the patient has the major or minor form. Anemia symptoms are almost always going to be present. These patients can also have extramedullary hematopoiesis, so that frontal bossing and enlarged jaw, and they can also develop hypersplenism based on the severity. Just like alpha thalassemia, again, suspicions should be raised when you see a low MCV that's out of proportion to the anemia, and the lab anomalies will be based on the severity. Just like alpha thalassemia, the best initial test is going to be hemoglobin electrophoresis, and genetic testing is the most accurate. So, as you see, alpha and beta thalassemia clinically are pretty much the same thing. The difference is who it presents in. Alpha tends to present in Asians and blacks. Beta tends to present in Mediterraneans. But the race is not a way to diagnose it. So you have to use hemoglobin electrophoresis to make your diagnosis. Okay, here's the genetics of beta thalassemia. So normal, you've got 2 normal betas. Beta thalassemia minor means you have one normal beta and a beta 0, or one normal beta and a beta plus. And beta thalassemia major is going to be two beta zeros, a beta 0 and a beta plus, or two beta pluses, and those are all abnormal genes. So they don't have any normal beta genes. And generally, if not always, this is fatal if not diagnosed in the first year of life. So any patient with beta thalassemia major, or you may hear it referred to as Cooley's disease, they're going to have it's either going to be a pediatric disease on a pediatric question where they've got anemia, or you're going to have an adult who is already carrying a sticker on their forehead saying, I've got beta thalassemia major because I was diagnosed as a baby. This is not something that gets diagnosed when you're 40 years old. Okay, the treatment for beta thalassemia, again, the exact same as alpha thalassemia. Why? Because we have the exact same problem. You don't have alpha globin, you can't form globin, hemoglobin A. If you don't have beta globin, you can't form globin. You can't form hemoglobin A. So it's the same thing. It's just a different part of the production chain. So generally therapy is going to be restricted to patients with beta thalassemia major. Why? Because those tend to be the only patients that have clinically relevant thalassemia. Iron supplementation is going to almost always be, it's always going to be contraindicated, and certainly will be the wrong answer on the USMLE. I don't foresee them throwing a beta thalassemia patient at you who also has iron-deficiency anemia. That just sounds like too bizarre of a question for the USMLE. So when it comes to treating a patient's thalassemia, be it alpha or beta, iron supplementation is the wrong answer. Transfusion is the therapy of choice when a patient has symptomatic thalassemia or if they have a hemoglobin of less than 7. Our goal with alpha or beta thalassemia is going to try to keep the hemoglobin above 9.5. And this is going to become more important when the patients become older, because remember that as you become older, your heart weakens a little bit, and your heart relies on oxygen because and you're going to need your blood to be carrying ample amounts of oxygen because you're going to have a small amount of stenosis in your arteries. So when it comes to older patients, we want to make sure that their hemoglobin is nice and high, that they've got hematocrits that are no less than 25, up to 30 or better. Younger patients, it's not so much a big deal. So with beta thalassemia, as the patient becomes older, it's going to become more important to keep that hemoglobin nice and high. Again, like alpha thalassemia, and that goes for beta thalassemia and alpha thalassemia. You got to keep their hemoglobin high. That goes for any kind of anemia. It's more significant in elderly patients because if you don't have red blood cells carrying oxygen, it's just as bad as if you've got stenosed arteries. Okay, so patients who've had repeated transfusions, as mentioned for alpha thalassemia, they're at risk for hemochromatosis. Therefore, you should be measuring their serum iron levels, and always, if they've got signs of hemochromatosis, or per protocol, you can use deferoxamine or deferoxerox for iron chelation. And if they've got hypersplenism, splenectomy will be indicated. Long-term complications are the same as for alpha thalassemia. So this is a normal smear. I wanted to show you a smear not because you're going to see a smear on step 2 or 3, but because you may get the reports of what the smear looks like, and so I figured showing you what it looks like will help ingrain it into your mind. So this is a normal smear. You got a little bit of whiteness in the middle of the cell. They should look like a donut. Okay, they shouldn't look like a hula hoop. They should look like a donut, like a red donut. And here is a normal, looks like a neutrophil, and this looks like a, I don't know. Don't ask me on my hematology. Basophil? I don't know. Whatever. Most importantly, though, neutrophil, it's not hypersegmented. You only got 4 segments. You don't have more than 6. and you got red blood cells that look like donuts. Okay, what's this? What have you got here? You got a lot of abnormal stuff. There's a normal appearing cell. Then you've got target cells. So these target cells look like eyes or like a target. And then you've got something called a poikilocyte. And a poikilocyte is an abnormally shaped red blood cell. This is a poikilocyte. This is a poikilocyte. This might be an acanthocyte, but this is a poikilocyte here. I'll show you a better poikilocyte. Poikilocytes they tend to show up in a lot of things, but they show up in thalassemia. So target cells are what you really want to look for in thalassemia, though. Okay, so here's some more poikilocytes. Here's one. Here's one here. Again, that might be an acanthocyte. Here's one. Look at that. That one looks like an amoeba. So these are all poikilocytes, and that can happen in. And this might be your target cell here. So this could easily be a patient with thalassemia. Okay, here's iron-deficiency anemia. See, these aren't donuts. Have you ever seen a donut looking like this? Hope not. So some might be normal. This one looks pretty normal. This looks like a donut. But this looks like a hula hoop. So these are abnormal red blood cells. And they are iron-deficiency anemia. And it just looks like iron deficiency because you don't have the hemoglobin. You don't have the red stuff. Okay. So sideroblastic anemia. Disorders of incorporating iron into protoporphyrin. Okay, so remember way back to that diagram I showed you. Sideroblastic anemia is any disorder that ultimately leads to a defect in the production of heme. There are a ton of steps in the production of heme, and you better not memorize them because you're wasting up brain space. So there's like 13 steps to produce heme. The most important one is protoporphyrin plus iron equals heme. But there's a ton of steps. All of those together are called the porphyrias. But sideroblastic anemia most commonly is caused by a defect in the synthesis of heme when you're talking about iron not getting incorporated into protoporphyrin 9. So sideroblastic anemia results in a low hemoglobin because you can't make heme, so you can't get hemoglobin. A high ferritin because you've got all this iron, but it can't get incorporated into the heme to make the heme. You've got all that iron held back. You've got a high serum iron, which again is backed up, and a normal TIBC. Transferrin is not affected by this disease at all. The typical findings on smear is basophilic stippling, and what those stipples are iron granules. So really, when you think of sideroblastic anemia or any of the porphyrias in general, because you can't get iron to form the heme, you're going to get iron all backed up in the blood. And you get all this iron backed up in the bloodstream, in the red blood cells. Those form these granules, and those are the stipples that you see. Now, there are various porphyrias that can cause sideroblastic anemia, and those can be congenital, but the vast majority are acquired. What causes sideroblastic anemia? Excess alcohol use, by far the number one cause. Vitamin B6 deficiency, vitamin B6, not vitamin B12, vitamin B6, that's pyridoxine. So vitamin B6 deficiency can cause sideroblastic anemia. What else do we see in vitamin B6 deficiency? Angular cheilitis around the lips, inflammation of the tongue, glossitis. Copper deficiency is another thing that can cause sideroblastic anemia. Heavy metal toxicity, and that's because it's going to interfere with iron being incorporated into heme. And then certain drugs can cause sideroblastic anemia. Isoniazid, which is an anti-tuberculosis drug, primarily because that interferes with vitamin B6. chloramphenicol, which isn't prescribed as much anymore, and some of the oral contraceptive drugs. So this is a disorder of incorporating iron into protoporphyrin, which is the final step in the synthesis of heme. Sideroblastic anemia is common, though, to all of the porphyrias. It can be congenital, but the vast majority are acquired. The symptoms will include anemic symptoms because we're not getting the production of hemoglobin. This is common to all of these diseases we're talking about, along with symptoms associated with the underlying cause. So what is the underlying cause? Well, we just talked about it. Excess alcohol use, vitamin B6 deficiency, copper deficiency, heavy metal toxicity, isoniazid, chloramphenicol, oral contraceptive drugs. So if a patient has anemic symptoms along with, if they have anemic symptoms and they're an alcoholic, first off, you should be thinking the more common cause, which is going to be macrocytic anemia, but they can get sideroblastic anemia. So with alcoholism, think of past history, alcohol smell on breath, or alcohol in the blood, gait disturbances, hepatomegaly, disturbances on liver function tests. Chronic alcoholism can cause sideroblastic anemia. Heavy metal toxicity, this can cause neuropsych symptoms, delirium, insomnia, tremor, memory loss, psychosis, abdominal pain, and renal failure. By far, lead toxicity is going to be the one that's associated with sideroblastic anemia. And then vitamin B6 deficiency, this is common. History of taking isoniazid. When you're treating tuberculosis and you're giving isoniazid, which you do for 9 months when you diagnose somebody with latent TB, you've got to give them B6 as well. And sideroblastic anemia is one of those reasons. Cheilitis, glossitis, and conjunctivitis, those are all characteristic signs of vitamin B6 deficiency. So if they've got those things too, think vitamin B6 deficiency. And for diagnosis, peripheral blood smear is really going to help you establish your working diagnosis because you're going to see those granules. And you're going to need a Prussian blue stain to do it. So your regular old H&E stain, not going to cut it. You need to do a Prussian blue stain to find iron granules in the red blood cells. But other tests may be necessary to work up the specific cause. So just seeing iron granules, that doesn't tell you if it's alcoholism, if it's heavy metal toxicity, if it's a patient taking isoniazid, if it's a patient with B6 deficiency, etc., etc., etc. You need to do other tests to work up the specific cause of sideroblastic anemia. So here's sideroblasts. So here you've got iron granules here in your red blood cells, these little blue things, and that's why it's called a Prussian blue stain. Okay, so the best first step in any patient with sideroblastic anemia is going to be vitamin B6 administration. And the reason is because vitamin B6 deficiency is either directly or indirectly the most common cause of sideroblastic anemia. Now, with patients with alcoholism, they tend to lack the B vitamins in general, and that's why patients with alcoholism are prone to getting the macrocytic anemias, because they lack B12. You have no B12, you can get a macrocytic anemia. If you have no B6, you can get a sideroblastic anemia, which is a microcytic anemia. So, alcoholism and vitamin B6 deficiency, they kind of go hand in hand. Patients with alcoholism, they tend to get sideroblastic anemia because they're vitamin B6 defective. So the best first step in therapy overall is going to be vitamin B6 administration. And in most patients, they're going to respond to it and the anemia is going to clear. And if they respond to vitamin B6 therapy, then that indicates that that's the etiology. If they have a history of alcoholism, then that could be the cause. If they've got a history of taking isoniazid, or if they've got cheilitis, glossitis, conjunctivitis, then it's a direct vitamin B6 deficiency. So a B6 response will indicate that that's the etiology. But we always start them with a trial of B6. Transfusion should only be performed if anemic symptoms are present. Transfusions certainly are not necessary. But who are you going to perform transfusions in before other people? The elderly. Because a 7.0 hemoglobin in an 80-year-old man is much more emergent than a 6.9 hemoglobin in a healthy 25-year-old, even though you may transfuse both of them. And ultimately, treat the underlying cause. If you have not figured out the underlying cause, consider a bone marrow biopsy. Okay, so since I talked about chelators, I just wanted to quickly go in heavy metals. I just wanted to quickly talk about the different heavy metal toxicities and what you use to chelate them. I'm not going to talk about the symptoms of each of these heavy metal toxicities. Of course, iron being hemochromatosis, lead, mercury, copper, and zinc. These are the drugs that we can use. Zinc toxicity actually really doesn't come up on the USMLE, but EDTA if anything. So here you can write these down. Okay, anemia of chronic disease. So the basis of anemia of chronic disease are twofold. And I only wrote one of them down because it's the more important one, but there's really two things going on here. First, you have inflammation, and that inflammation increases the amount of hepcidin. Hepcidin is an acute phase reactant, and what hepcidin does is it blocks iron absorption. It doesn't directly block iron absorption, but essentially what it does is it reduces the absorption of iron in the liver. So hepcidin blocks iron absorption, and there's more hepcidin when you have an inflammatory state. Inflammation also increases ferritin. And what does ferritin do? Ferritin hogs iron from the red blood cells. So it's going to reduce the formation of hemoglobin, despite the fact that you may have normal or high levels of iron in the body. Now, inflammation will also decrease transferrin production, and that's done to reduce the amount of iron that's carried extracellularly in the serum. And that's done so that you're not feeding iron to some of the things that may be causing inflammation. Most of the time when you have inflammation, you don't have any of those bacteria around. You may have an autoimmune disease, but your body's programmed to think, oh, I've got E. coli, I'm inflamed, I better not feed E. coli iron, and so it does this. Now, another thing that anemia of chronic disease is caused by, is the fact that when you have a chronic inflammatory state, all of those interleukins and all of those things that are associated with inflammation, they shut off blood cell production, or at least they slow it down. And so that's another thing. You get lower production. So you get an interference with the ionization of red blood cells, and you also get a decrease in production. So what does all this mean? Well, you're going to have a low hemoglobin. There's not enough iron brought in to make it. So you don't get iron brought in to make it because you've got all this hepcidin that's made from the inflammation. You're going to have a high ferritin. Why? Ferritin is an acute phase reactant, and it also holds and hogs iron from the hemoglobin. You're going to have a low serum iron, and that's because iron is held up in the cells by ferritin, and you're going to have a low TIBC. And that just has to do with the fact that you don't have a high serum iron, so there's no need, or you don't have an iron deficiency, so there's no need to make TIBC, or there's no need to make transferrin. Don't confuse ferritin and transferrin. They can be very confused. Transferrin is extracellular, and what it does is it increases when you have iron deficiency. Ferritin is an acute phase reactant, and it increases when you have inflammation, and it hogs iron from what could potentially become hemoglobin. So the overall purpose of anemia of chronic disease, and it does serve a purpose, really, it is a normal body reaction, is to hide iron away from the serum where bacteria could potentially get it. So you're hiding the iron from the hemoglobin, and you're hiding the iron from the serum. And that's done by increased ferritin to hog the iron away, and a blocked absorption to prevent iron from getting in the first place. So diagnosis, the MCV in anemia of chronic disease can be normal or slightly low, and iron studies will reflect this in a high ferritin, and this specifically distinguishes it from iron-deficiency anemia. The typical patients who have anemia of chronic disease kind of look like the typical patients who may have iron-deficiency anemia. 45-year-old woman maybe has a chronic disease, endometriosis, maybe doesn't. Maybe has iron deficiency, maybe has anemia of chronic disease. You get that ferritin back and it's high, you know darn well that her iron stores are fine and she's got anemia of chronic disease. If she's got low ferritin, then her iron stores are low and she's got iron deficiency anemia. Now the reticulocytes are going to be low. Why are they going to be low? Because of those inflammatory mediators. Remember, I said that blood cell production gets kind of ramped down a little bit because of the inflammatory mediators. So your reticulocytes should be in the less than 1% range, certainly less than 1.5%. If there are any other cytopenias, remember, anemia of chronic disease only affects red blood cells. If there's any other cytopenias, then, or if there's any abnormal looking cells on the smear, you should get a bone marrow biopsy. It does slow down hematopoiesis in general, I will say, but you shouldn't get a leukopenia from anemia of chronic disease, and you shouldn't get a thrombocytopenia from anemia of chronic disease. Those inflammatory mediators don't do that. However, they are strong enough to slow down the production of red blood cells because red blood cells are produced so fast. But if you have a pancytopenia, that's not really looking like anemia of chronic disease. So you should probably get a bone marrow biopsy on a patient like that. Anemia of chronic disease should be primarily limited to red blood cells. It should primarily be a red blood cell disease. And the focus of therapy for anemia of chronic disease is going to be tailored towards treating the underlying cause. Transfusions are rarely necessary. However, older patients, if you need to, if that hemoglobin starts dropping, if that hematocrit gets below 25, 20, that's kind of a danger range, then yes, transfuse them. Okay, so this is just a recap of the iron studies in microcytic anemia, mostly looking at in thalassemia that we've got normal iron studies because this isn't a disease of hemoglobin formation, namely. It's a disorder of globin production. And with sideroblastic anemia, you can't incorporate iron, and so because you can't incorporate iron into that heme, iron is going to be backed up, and you're going to have excess serum ferritin to hold it and high serum iron. But all of these diseases are going to show hypochromia, and with iron deficiency anemia, you'll see those small cells that look like hula hoops. With thalassemia, you get target cells, poikilocytes. Anemia of chronic disease, primarily you're just going to have a hypochromia. And sideroblastic anemia, you get that basophilic stippling, those little blue spots that you see on Prussian blue stain. And that is it for microcytic anemia.